So yeah, for those who've seen these before, hopefully what they'll realise is this is an exciting time for us because it's our first four-person chat, and we're not sure how it's going to work, and we're going to try and sort of, I'm going to try and police it, so we're not all talking at the same time. The internet connection seems to be struggling a bit more with with four of us than it normally does with three of us. So apologies in advance if we pause or if there's a bit of a delay. But I'm sure it will be worth it. And tonight's discussion is manual therapy, or joint mobilizations, joint manipulations, and maybe if we have time, depending on how we're doing, we'll talk about soft tissue as well. That might form a part too. So loads of questions came in. I think it proves it's an interesting topic. I know the reason we've got these two guys here is because they in their respective countries they teach it a lot. They're in the position of educating it. So we thought, who better to sort of just talk it out, and we want to talk about the elephant in the room that is the evidence base, or possibly lack thereof. We want to talk about its clinical applications, the whens, the when nots, the whys, the outcomes, etc. And then we'll just kind of go from there. And obviously, as always, Craig's going to pitch in with the live comments as they come in as well. So I'll start the ball rolling, if I may, and we'll talk about the difference between mobilizations and manipulations, which is a question that a lot of people actually have emailed and asked. I'm right in saying one of you does quite a bit more mobs and the other quite a bit more manips. And I think if I've got it the right way around, Linane, you don't do manips. Is that correct? So maybe correct. You want to start by, maybe if you could talk to us about what a joint mobilization is, and then afterwards Ted could come in and talk about what a joint manipulation is.
Yeah, sure. Whilst I don't generally do manipulation, it's been part of my training, but over the years for me, I've favoured mobilisation work. And if you wish, the key difference is, if you imagine there are 5 levels of applied force you can place upon the tissues of a joint, taking them in an oscillatory manner from grade 1 through to grade 5. Grade 1 to 4 would fall within the mobilisation level, and grade 5 would be considered to be a manipulation level. Grade 1 to 4 means that you take it from the very beginning of the joint available range. Grade 4 means you're getting towards the very end of the range, but you're not pushing it any further into its physiological range, full physiological range. And so manipulation would be that very, very end level, which requires a thrust component to it, whereas mobilization is very gently an oscillatory movement with a degree of force, but not one that's actually a thrust. Each of the two techniques have their own particular goals. So that's that. In terms of manips, it's not something I do. I did have to do my own thumb recently, which was quite interesting, particularly because it was a very painful thumb. But other than that, no, I don't do that. So maybe Ted. In the UK, Dave Cashley would be the guy to head up on that one. So I don't want to make more of a fool of myself than that. Go on. Ted's more the manips guy, I think.
Yes, and it sounds like, Ian, you're describing the Maitland's method, or the Maitland's chart of those grades of mobilization. I love Maitland's, the way he articulated it, in that what helped me really understand the difference between the two is mobilization is the application of a passive force at a joint's end passive range of movement at a speed and force that the patient could overcome. And this is really on that 5 grade scale. This is usually around grade 4. Whereas manipulation, it's the application of a high velocity force, so it happens very quickly, but it's a passive force, again, at the joint's passive limit, at a speed that the patient could not overcome. So basically, it's all over before they could react or do anything to oppose that force. And so, yes, it is about speed, but I think the important thing is that manipulation has the therapeutic benefit, or the application of that force. While it does involve speed, it's still within the joint's capabilities. So it's at the paraphysiological limits, but not beyond them. And that's but because it's right adjacent to it, that's where the risk comes in, where if you go too far, then you run the risk of damaging the joint. And I think one of the great advantages of the high velocity forces is the neurophysiological response. So we get a lot more stimulation of particularly the type 3 mechanoreceptors in response when we apply a high velocity force. But there's always a bit of mystery and often a lot of theatre about using manipulation. And maybe you see if the audio goes here, but I will just double check that I've envisioned. Watch this. And usually in a room when you're teaching a manipulation, you get that noise. And, oh my God, it's not, it doesn't cause arthritis. It's just a release of, well, the theory is a release of some of the hydrogen gas within the synovial fluid. And particularly with patients, sometimes they will think, you're doing something harmful. The analogy I'll use is, imagine a suction cap on a window. You stick it on, and then you're pulling the tension, and when you pop it off, it's that rapid change of pressures difference from inside the suction cap to the outside. And that's literally what happens with the synovial joint. You get that rapid change and you get that noise that happens. Just the noise. The great thing is that cavitation effect stimulates synovial fluid production. So particularly for arthritic joints and joints that you want to improve the lubricant within the joint, that's the big advantage. But typically in my clinical practice, I will mobilize joints, and that's where I get all my qualitative feedback. And then where I feel the restriction or the hydraulic tension in the joint, I'll apply that high velocity force to generate that release in I suppose, as quickly and as effective as possible.
There you go. Beautifully said.
Lovely.
Beautifully said.
Perfect. Beautiful. So, because we got so much to get through, what we'll probably do is, rather than ask you both for your opinion on all the questions, we'll probably just divvy them up. And if one of you's got something they're really desperate to add, then obviously do. But let's just we'll come to the evidence in a minute, because that's the bit that I think we all like to speak about. Like I said earlier, the elephant in the room. Let's talk about the clinical applications first. So, when do we do this, and also when do we not? I mean, one of you can take when, and one of you can take when not. That might be the easiest way to do it. Ian, do you want to start?
Yeah.
Take whatever one you want.
Yeah, I'll take a little bit of a look at the when. I think at one level, the when is what you're presented with. First of all, what's presenting to you, what kind of condition you might be dealing with. So any time that I might want to address a situation whereby there's a limitation of joint movement that isn't a risky situation, such as somebody who's had a crush injury, you wouldn't want to necessarily be involved in doing something with them. But if somebody's got a limitation of joint movement because of an injury that's healed, if you wish, or somebody who's in I would tend to say subacute stage rather than acute stage, where you can use mobilization work on them, I'd be happy to work in those situations to try and improve quality and whatever available range improvement I can gain with that. But also working in mobilizations at that level allowing me to get some stimulation of synovial fluid being released from within the synovium. And also it can also help in terms of reducing some of the pain by gaining movement back in there. So if I've got somebody with pain that I can mobilize a joint on without risk, then that can help reduce pain and enable movement. Of more recent years, I've been using very gentle mobilization techniques under a level of traction in order to try and get a large afferent feedback into the nervous system. And it's an area that particularly interests me, but I've been using it quite a lot in people who would be classified as perhaps having a muscle guarding component to their injury, and who have not managed to get anything like a great success for themselves elsewhere and through other means. I'm not saying it's a wonderful thing, but over the years working very gently with those people using mobilization techniques, I've managed to find a number of people who responded to that and significant muscle guarding problems have actually managed to reduce. Whether that's what I'm doing, whether it's because it's their lucky day and they've got better, I don't know, but that's an area where I use it as well. So basically addressing injuries that can be treated using joint mobilization to improve quality of range of movement, and then certainly looking at some of the chronic long-term conditions that I've been using it on recently in the last few years, and trying to catalogue those has been a helpful thing for me. Don't know if that helps to give some idea. Other areas, people who've got digits, when you've got the nice little hammering and clawing on the toe, using certain techniques to try and enable the joints and the toe to become more flexible. That's been a useful way to do things. Neuromas, more Dave Cashley's area, but I do find using joint mobilizations can help reduce something of the discomfort on some of them, I guess, depending on the size and if it's going to respond to that kind of work anyway. It's not going to be a miracle cure for neuromas, at least from the mobilization point of view. I think Dave's got some good stuff on the manipulation side of it. Does that help to answer some of the question, or?
Yes. Can I speak?
Yeah, beautiful. Yeah.
So I want to
go.
kind of take the camera back a little bit and think about what the physiological objective with mobilization and manipulation, for that matter, joint mobilization. My key objective, and particularly when we're dealing with the foot and the ankle, which is just laden with so many collagenous structures. You've got the capsules, the ligaments, the tendons. I see the key objective as being able to improve the range of motion in hypomobile joints that have come about because of connective tissue restrictions. And this has come about because of the collagen cross-linkages. Literally, when let's go back to our physiology university days where we learned about Davis's law. And in Davis's law, we've got the ligaments, soft tissues, when they're put under tension, will gradually elongate. But if they're not under tension, or if they're in a lax state, they will gradually shorten. And we use the expression in our trainings, connective tissues always adapt to their shortest functional length. And we know it in lay terms as the use it or lose it cliche. So if we have a joint, the classic HAV and the abducted hallux, and that joint is kept in this position, the tissues are going to adapt to their shortest functional length, according to Davis's law. So particularly the capsule and the collateral ligaments on the lateral side of the first MP joint will gradually shorten. So with mobilization, manipulation techniques, you're literally going to be tearing them apart to release that so that the body can then adapt and heal and restore in that position. And the key thing here is that the tearing apart, physiologically, that's literally what happens. This is where sometimes the risk of, if you try and do too much too soon, you can run into trouble. So with that release of collagenous cross linkages, that's when you can lead to improvement in joint range of motion over the long term. And when I talk about long term, research is very clear that collagen cells to turn over, the old cells to replace with new healthy cells. Kier et al. In the Sweden, Scandinavian country, found radiographic isotopes and saw how long it took. It takes about 6 weeks. So good ligament injury would generally take about 6 weeks to fully recover. So we base our mobilization treatments on to release those collagen cross linkages if that's the underlying cause of the musculoskeletal condition you're dealing with. So you've got to make sure you kind of put that in context. So it's kind of the umbrella. Release those collagen cross linkages. It's going to take physiologically a cycle of around 6 weeks. So you work with those tissues over that 6 week period of time. And then during that time, you also assist the neuromodulation of the joint receptors in that example of the first MP joint. And so that's another way that it's thought that it helps aid the gait control theory of pain, and you get some of the symptomatic release there. But that's one of the key things is that, like right now, all of us who are sitting and watching this, your connective tissues around your hip joint, around your knees, around your ankles, because of that flexed position, are going to be adapting and shortening. So the important thing here is to, I think, is be clear on what your objective is. Ian, when you talk about muscle guarding, that's where the gentle and the neurological input, I think, has more of an effect. I guess my focus has been on the collagenous tissue restrictions, and given I'm so butch and tough, I like to do the hard stuff. So
Ted, if you've got I'm interested in what you're saying from that point of view. If you imagine you've got a situation whereby you've got a restricted first ray in terms of its ability to plantar flex. I mean, none of us are here trying to catch each other out. We're asking genuine questions. Would you be looking, and let's just say it's between METs 1 and 2, and it was appears to be a collagen shortening. Is that something that you would look to use that collagen release approach?
Yeah.
I asked the question because I think I understand where you're coming from there. Whereas for myself, I would be applying very, very little force whatsoever, just a very gentle oscillation and allowing the ligaments, if it's not going to work that way, working it at its end at that particular point, gently teasing it down, gently teasing it up. So if you wish, try and allow that tissue to come to its natural, extensible length.
Yeah,
that makes some sense.
I understand what you're saying there. I don't think you can apply to get those collagen cross linkages released. You need to apply a reasonably significant force. So that's where I would be taking the joints to its passive limits and then applying the force in the direction of correction. But if you're going to isolate a joint, say in the midfoot or even the forefoot, the crucial thing is looking at, is that the cause of the restriction, or is that secondary to something else or some other compensation that's going on? And I think this is where it behooves us to look at the whole kinetic chain and see what structures are influencing, because I picked up this great expression that the Italian therapists use, and it's that, I've not heard it in English, but it might also be in English, but he who screams is not the guilty. I think that's how it translates. So basically where the symptoms are, that's the victim, but the guilty one, the cause, is actually coming from somewhere else. And when we're dealing with the foot and ankle structure, the complex compensation patterns that occur. And my old friend, and I always think that the first joint when we're dealing with foot and ankle and foot and leg issues is checking the center of the universe, which translates in Latin to astragalus, which of course is the name of the talus. So that's my plug for the talus, and focus on the talus first.
That's interesting. So coming back to the idea then of the releasing the cross linkages and level of force applied, I guess if I'm applying force to the example being the first and second metatarsal heads, or even second and third, and just a gentle oscillatory downwards and upwards, superior or inferior glide of that, but I get that range of movement, but I'm not applying a force or a level of force that necessarily is releasing cross linkages.
Yes.
But I gain that. Coming back to the area of the astragalus and the talus, I can understand where you're coming from on maybe trying to work with the talus, trying to improve quality, range of movement within its various ranges and its directions of movement that go on. For me, I kind of found, I guess we're moving into that kind of discussion, really, I suppose, that Griff wants, which for me, I've found by looking at the more current models of foot function, the Nestlable, the Lundgren, I've moved away from the talus as being the crucial, pivotal thing in terms of understanding foot function. Mm-hmm. I think it understands the relationship between the foot and the leg, and I'm no biomechanist, so the guys will shoot me down on that one. But as I've begun to look a bit more at Nestlable, Lundgren's work, looking at the levels of movement that may be occurring, it's redirected my thinking about what am I looking for passively, and it is a passive that you can't translate to active. I understand that. And I found myself moving away from the talus as being the key and crucial bit. For me now, talar navicular, navicular medial cuneiform seem to be the more significant ones, followed often by the second metatarsal head. Now, I'm not saying that disproves anything, but I think as I've looked at playing with the foot increasingly, it's made me, and try to take on board that level of understanding of foot function. It's taken me increasingly, if you wish, away from the talus itself. Don't get me wrong, I use it a lot, but it's no longer my focal point in assessing the foot for conditions.
Yeah. Okay. From my clinical experience point of view,
Can I?
I've still gone. My focus is still on the talus, just as a result of my clinical experience, and so, and I'm open to change. I like Craig's.
Well, you're moving to it,
where the evidence takes me. That's at this stage, part of my evidence base is literally my own clinical experience.
That's fair enough. Understand that one. Yeah.
Can I bring in the evidence base? Can we talk a bit of evidence, if that's okay? My understanding of the evidence base is that it's far poorer than we'd like it to be, and I know that's obviously the case with a lot of things. But I read a paper that suggested, I think it was Joel Bielowski, if I've pronounced that correctly, and it basically suggested, and it actually resonated with me given what we talked about 2 weeks ago with the Payne science talk, and then what we now know about pain. It resonated with me quite a lot, and that was that the force production, the actual manual therapy, sort of initiates this cascade of sort of neurophysiological responses, and it's the nervous system, both central and or peripheral, that's actually the reason why things work, rather than us realigning, repositioning, changing the actual structure of something. It's the nervous system, and given what we know about pain, that makes a lot more sense to me. So I wonder what you both kind of thought about that.
Bielowski's got two really quite useful papers, and particularly on placebo. And I'm happy to put the titles of those papers up on later on. Well, one of them was more a comment review that he put into something, and then the second one is a paper where they look quite closely at placebo, and really looks at placebo as a very positive, influential, important part, perhaps, of any kind of treatment, but particularly within manual therapy having a role. And you're right, in his review article and also within the other paper, they discussed the idea of it being a potential winding up of the neurophysiological system. So whilst I'm talking about talar navicular medial cuneiform, I'm talking about assessing passive movement where there is limitation. If I'm talking treatment, I'm talking about maybe taking the foot and its joints into a position where I can maximize as much neurophysiological feedback into the system as possible as part of the wind-up mechanism. Does that make some sense to trying to address that? And that's what I found to be extremely helpful. Similarly, kind of working at a level and a slow pace that maybe has, in that instance, if it's possible, a greater impact upon the Ruffini corpuscles rather than the Pacini ones. Ruffini being responding to long, slow, sustained stretch with a lateral movement glide towards it. That's really where my head's been going with all that, which is coming from the Bielowski stuff, the neurophysiological stuff that's coming through, which I don't always understand. It's way above my head. And then obviously you've got your Payne science stuff as well. So for me, I'm going to problem. It's a neurophysiological thing. That's what we're working with. It's the means and methods that we might do that. This, from our point of view as a manual therapist, is important. I'm not into aligning joints particularly, because whatever I align passively may not necessarily stay there actively. And necessarily a talus being put back into a particular position isn't necessarily always the case that it's going to solve the problem, because the talus can come out and the problem's still gone away. So from that point of view, I think there's a whole area of study and work to be done. So, sorry, I'm not, the placebo question is a really good question in the context of neurophysiological change and what we're aiming at.
Great. So I'm just, if I can contribute a little here. I I also have a premise that I work with in using manual therapies, and that premise is this: everything works best when it's in the right place. And I think that's a universal law for my desk here, as well as the human body. Now, what is the right place? I know we have a real challenge in, if we're trying to quantify or mechanically say this position of 12 degrees and the axis is supposed to be here. That's we're going to get ourselves into a lot of hot water here. However, if we think of each joint has a workable, each synovial joint will have a workable range. And if it's pushed to its end limits, it makes sense to me physiologically. That's where we're going to get a lot of the clinical symptoms that occur with our patients that come seeking us for help. And let me ask, for everyone who's watching, listening right now, have you ever in your life been sitting down at your desk, Craig, this will be a good one for you, and you felt tension in the muscles in your neck or one side of your shoulder? Like, have you ever had that happen? Of course, we all have. What, from a neurophysiological perspective, my reasoning with that is, for some reason, and let's take, if I can use the chiropractic word here, say that often the straight chiropractors will say, well, what's happening there is if there's a vertebra that's either stuck or out of position, there are working muscle fibers that are trying to pull or restore the position. And I think from a neurophysiological perspective, that's often what happens. The body gets feedback from the mechanoreceptors, tells the brain says, okay, well, I'm going to get those muscles here to try and put things into a better or more efficient position, according to what the wisdom of the body knows, not from an outside scientific research perspective. So you've got these working muscle fibers. What if those muscles are unable to generate sufficient force to improve the position of that vertebra that's responsible for that muscle tension? My view then is the only way that can be improved is from an outside force. And that's where mobilization or manipulation can then work. Yesterday I had my regular chiropractic checkup and had that exact personal experience. I can't, through exercise or stretching, get to the option. She palpates my spine, feels those working muscle fibers, applies a force in the direction that the body's already trying to help itself. Now, I know this is kind of, to quantify this is more, I guess we call it deductive reasoning, is that if the body's muscles are trying to pull things into this direction, then let's work with that direction of correction because the body says this is going to be the right place or a better place. But the difficulty we have with the foot and ankle is the muscle mass, the volume of muscle in relation to bones and collagenous tissues is so much less compared to what's happening up here. So I know a good therapist can palpate the muscles along the spinal column, and they'll feel where the tension is and where muscles are relaxed. To do that in the foot and ankle, it's taken me years, and I don't think I'm particularly wonderful at it, because we just don't have the same ability to, we don't have the muscles working as well to try and improve that position. And then when you've got the talus, which doesn't have any muscles attached to it anyway, what do we do there? So I may have drifted off a little bit here, but I wanted to just make that point, is that we can look for we try and quantify and get the evidence and the research that says, yes, this working muscle theory is, we can quantify it. But if we think about it, we've all experienced those tensions in our body. What is actually going on here? And yes, you can release the muscle and give it some relief, and you give it some heat treatment or some stretch and massage. But if the cause of the problem is due to a displacement or a shift or a blockage of a certain bone that the muscle is attached to, I'm not sure that you're going to get the best long-term result unless you release that joint restriction or the underlying cause. And again, it comes from the underlying cause. And this is where it's like, how do we know what that underlying cause is? Well, look, I'm open to assessment methods and other people's experiences with that, because that's the art, I think, of manual therapies, and where good hands-on practitioners will use that the tactile sense to determine that.
Yeah, let me just jump in. I'm conscious of the time. We've gone over 30 minutes already. I know Ian's had been emailed previously or messaged a couple of questions, and we have had the exact same question posted by Sean Savage. So Ian, I don't know whether you want to address the sublux cuboid issue.
Yep. Yeah, definitely.
What's one of those?
Yeah, well, good question. So I tell you, let's give it a bit of background, because we've all talked about this. We've all got previous discussion, albeit not face to face, and the issues I have with what's just been said, as well as what we're going to come on to say, is this contention that we know we have this ability to know where individual bones should be. They have a good place and a bad place.
Yeah, agree with that.
It's not supported by data whatsoever.
No,
not only is it not supported by data, it's pretty strongly refuted by both. Human variation is one thing that there's no disagreement on. So the other concern I've always had, and this applies to the cuboid, but everything, is when we use this kind of language with patients, displacement, malalignment, it has this horrific nocebo effect. And we know that pain is all about threat, perceived or real. And nocebic language is a real feeder into that. And when we look at the hard time that chiros have had over the years for kind of getting people back, that kind of business model that we give them a hard time on, I've certainly seen people within the podiatry realms adopt that. Not that I'm blaming the clinician. Sometimes it's patient-led, because you've made the patient feel so fragile, vulnerable, hypervigilant, they catastrophize. They're essentially, I guess, reliant, dependent. And that, for me, as you all know, is my main kind of concern with this entire area. Now, when we come onto the cuboid, I have two issues here. And the first is that bar huge singular impact, I refuse to believe that the vast majority of lateral midfoot pain that walks into the clinic is cuboid syndrome that requires manual therapy. And my concern is that I see people who just indiscriminately go straight to that as their go-to before they've even got a diagnosis. But the other thing is, we think about the cuboid and its articulations proximally and distally. We think about its ligamentous sort of constraint. We think about the big tendons that groove it. Yet we're happy to agree that, some of us are happy to agree that it's got this ability to move and sublux and be the cause of all pain. Yet there isn't a single bone on the medial column. And you think about something like, I guess it would either be maybe navicular or medial cuneiform, similar with their proximal and distal articulations and their ligamentous orientation. There's no discussion of any bones in the medial column doing this. So I guess what I'd love from you two guys is where you sit on, well, I think we know, but where you sit on cuboid and its ability to sublux. If we believe it subluxes and this is causing pain, why are we not considering this for medial midfoot pain? Because to my knowledge, all medial midfoot pain that comes in isn't manipped in the same way that the cuboid is. And secondly, what's the retort to what hopefully is a reasonable comment about this nocebic effect that we could be having if we're not careful with our language? Ian, you better go first, or if we let Ted go, we'll run out of time.
All right. Okay, I think you got two things there, Ian. But first, I'm going to say to you, in terms of cuboid, I think I did read a paper or an example with some X-rays a while ago, and I can't remember what it was, of what would appear to be in a subluxed cuboid. So yes, can it happen? Yes, it can, depending on the injury. It's something I think I've come across twice maybe in my career. The rest of the times I've never come across it, and it's one of those things I look to be as a surprise to me when it comes through, rather than look for it. So I think there's the issue of the cuboid. Then the other one is the issue of pain language, and how we set things up. So I agree with you. I never mention the word sublux to almost any patient. A, they don't know what it means. B, then you waste half your time trying to explain what it means. You catastrophize their experience. I think there are times when I might use a language. It's almost very simple, childlike language to kind of explain why they might be getting some of their discomfort. And more often than not, I'm going to lay it in the vicinity of a soft tissue concern rather than an actual and articulatory concern. So I'd try to use language that actually is very gentle, very simple, and speaks of a very real possibility of something being changed. In terms of the actual cuboid subluxation, it's not something I've come across a lot. I do think it's overdiagnosed by a lot of people, but I think that's because one of the dangers of us, I'm not an educator, I'm a trainer, I know that because I went to Brighton University and said, should I do a PGC in this? And they said, no, because you're not an educator, you're a trainer. So what I'm trying to train people up, I'm trying to train them up in some ways that says, let's get rid of that language and let's not think about what's coming through as sublux. Let's think about what else it could be. And if we train people up to think like that, hopefully we get less of our people who've gone through the system talking in language that catastrophizes and not pulling on the idea of sublux all the time. I'm trying to be very quick with that answer. Is that okay? But Payne,
yeah,
language, Payne, science, very good. My background is that I once was a vicar, and one of the things that we had to do in that whole process was learn to be incredibly useful with our language. Not necessarily articulate, but useful with our language. So for me, I find it interesting that the Mike Stewart's course, and you've done that course too many times, Ian, by the sound of things, the language of that course is actually, if you wish, it's almost reminiscent of language that we were being used back in the 80s when I trained. Really quite interesting. So yeah, I'm all in favour of careful with language. Rare to see a sublux cuboid, but I do think they can actually get a bit stuck in their movements. With the stiffness there is probably more tissue. Does that help to answer the question? Or is that actually not answering?
No,
absolutely. I appreciate that.
My turn.
There you go. Go on.
The first thing is we haven't defined what subluxation is. And Dorland's medical dictionary defines it as loss of relationship of articular surfaces. It happens all the time, everywhere. I mean, just look at the hammer toes, claw toes, bunions that come into your clinic or came into today. Griff, when you mentioned about, we don't hear about people talking about the bones on the medial beam like we do with the cuboid. We do, but I think that's just notoriety, and historically, I absolutely see the navicular cuneiforms, base of the metatarsals. Do I see them displace from going to their end range position? Every day. Every training we run, we always find people where there are blockages, restrictions, and through mobilization, we can immediately release that. So for me, the analogy I'll use, and language with patients, crucial. Anyone who uses the term subluxation and any medical speak is, I think, doing themselves and their patients a disservice. The classic way that I would explain to a patient about what's happening with their joint, and if I felt that it was being restricted at an end range position. So imagine it's like a door, that has able to swing, but if your door is constantly slamming against its end position, eventually the hinges suffer, and eventually the frames, the architraves, things start perishing. And I think it's important to educate patients so that they understand what is going on with their body. Now, that's from my perspective, because I believe that joints get forced and put at their end position, and when a joint's functioning at its end limits, that's where the pathological forces occur on, particularly the musculoskeletal structures. So it may be due to that philosophical background. That's why I would be very happy to argue from a clinical experience perspective that particularly the bones in the midfoot, they shift and move and block. Every one of those bones that you mentioned as well, like the cuboid in a normal foot should be able to move some 3 or 4 millimeters, and you should be able to feel that. Intermediate cuneiform moves about 1 or 2 millimeters when it's not restricted. So these are to say that they don't move or that they don't get stuck. Maybe I hope I'm not misinterpreting your comments there, Griff. But they do move. They should move. They don't move much, but they got to move some. And if they don't, they dry out. synovial fluid dries up, you get osteoarthritis, and blah, blah, blah. The whole sequence of events takes place.
Ted, let me rudely interrupt you. And we talk again about the language you use and how patients respond to that language, and the consideration from you being that medical language in terms like subluxation would be terrifying. But terms like bones being stuck and doors slamming and the word pushing you've used there, ultimately just as likely, if not more. I mean, what we consider threatening language is sort of irrelevant, because ultimately a lot of the words you've used there would potentially terrify patients. And I think we now know how much that feeds into the pain mechanism. And just to clarify, I'm not suggesting that manual therapy doesn't have a place, nor am I suggesting it doesn't work. It's how we define work. It's the mechanism of effect, I think, is interesting for me. And I think we just don't have the data to support this realignment and repositioning. But the hands-on work, the careful use of language, the reduction of threat, and the central nervous system, that for me is close to being believable. But what concerns me is that isn't always the angle that people are taking. And I think if we're not careful, we have a very real ability by telling people we need to, you're stuck, or we need to move you or reposition you. We've got a very real ability to send people toward chronic pain or persistent pain rather than away from it.
Yeah, it's not been my experience. I've found that simple concept of, something's supposed to move and it doesn't move as well as it should, so we're going to work on getting it moving again. From my own personal clinical experience, I've actually found that somewhat liberating from a patient's perspective. It's like, well, that makes sense. And then adopt or recommend whatever treatment plan to deal with that. Certainly acknowledge that there's so much we don't understand about and the languaging and what happens inside clinics. Crucial area. I fully acknowledge that. I'm not saying I'm an expert in that area by any means, just based on my personal experience in dealing with a lot of chronic cases. Our clinics are known for getting the cases that have been everywhere else, haven't tried this. I think that's what I have to say about that.
Griff, I think you're flagging up.
Craig, anything that's coming from, how are we doing for time firstly? Anything that's coming from Facebook that's urgent to address?
No, sorry, I just had my mute button on because the dogs were barking again. Perhaps just move on to the next question, Ian. There's nothing really come through on Facebook. Lots of just comments, but no questions to pursue.
I'm scared of looking at the comments later on.
How are we doing for time?
Probably another.
Griff, can I just
another 10 minutes? Yeah, 45.
Can I just kind of come in, because I'm going to put a question to myself, really, which is, after many years of working in manual therapy and joint mobilization, manipulation, soft tissue work, all the various things that I've done, one of the big challenges I think is facing us as clinicians, and the questions that rightly asked, is where does it fit within the healing remit of what we're charged with within our profession? And I think one of the big challenges to us as practitioners and anybody who trains is we're no longer really dealing with joints and tissues. We're dealing with something far more whole, and particularly involving significantly the brain, the nervous system, the precepts that people come in with. And I want to flag up a paper that I think is really very, very helpful. It's by Gary Fryer. Some people may not have seen it, some may have seen it. 2017 publication. It's and I'll pop it onto the comments later on. There's two papers in which he looks at this whole discussion that we've been having about the role of manual therapy within the biopsychosocial model. And the thing we've got to bear in mind is I encourage people to use manual therapy, but actually it's a small part of the big overall healing picture. And if you take it at that level, you can actually enjoy using it and doing it. If you actually try and elevate it to something bigger than that, or elevate it to being the answer to what's presenting, or the answer, then I think that's where we actually encourage problems within our profession of its use. And so to kind of give it a proper place, which is just, a maybe bottom-up place, I think is really quite important. And the challenge, so the question I'm asking myself is, how well do I do that when I'm involved in training people? How well do I expose people to thinking about the biopsychosocial model in what I'm doing, and get them to recognize that's the much bigger and more important model rather than the model that I might present of actually intervention.
I think it's important that as clinicians we're very clear on what the indications and applications are of any treatment service that we provide, and so it's particularly as far as manual therapies go, we want to make sure that we are applying it where it's indicated and appropriate. I think one of the big frustrations that I certainly had in my early days was that a patient would come to me and I would, if they have a musculoskeletal condition, I'd provide a treatment that I was taught at university, and not getting the desired clinical outcomes or the results that I felt like I should be delivering. And so then I used to do a lot of referring to physios, chiropractors and manual therapists. And heck, I'm the foot guy. Why can't I do that stuff? And I think it would be really, I think it's essential for podiatrists. If you're going to be the person that people go to for their foot, ankle problems, then manual therapies ought to be in your armory, or ought to be one of the tools you have in your toolbox. And I agree, it's not the be-all and end-all, it's not the silver bullet, but it's a heck of a useful treatment tool, particularly if you're using a lot of orthotic therapy and you've got cases where there's supination resistance, and that's happening because of connective tissue adaptations, because they always adapt to their shortest functional length, and its body's been functioning like that all of its life, or they've sprained their ankle, or they're working as teachers, nurses, factory workers. Heck, the role of manual therapies, it transformed and revolutionized my clinical experience, my clinical direction. Yes, I'm an advocate. Yes, I'm biased with it. But I think I've got some history and track record to justify it, certainly in my own mind. And I've got to live with my own mind, and that's a hard enough battle. So
we're just about out of time. So I'm going to just ask one practical question at the end. I'm far from being any sort of expert in the manual therapies, but did use what limited skills I had. But one particular clinical scenario that I actually found really, really useful was those patients who came in 10 years after an ankle sprain, and they've got some pain somewhere. You struggle to work out what it was, but I always found mobilizing them, not necessarily a full thrust manipulation, really seemed to work really well on those sorts of people. So, by way of winding up, so I just wonder, got any practical tips for dealing with those 10-year post-ankle sprains that present with some pain, and they're not two are the same. So you can't exactly build up any experience in dealing with it.
All right, I'm going to stand up and talk about this one, because this is absolutely a classic. What you described there, Craig.
I'm just glad you got trousers on, mate. I'm just glad you got trousers on.
Well, shit, I had to double check. But the thing about, so that's a classic. That is, in my opinion, where the tailor shifts or displaces, and then people adapt their activities, or all the tissues adapt to it. It doesn't take much to literally reset a talus to improve its mechanical position. Keeping the bloody thing there is a fair bit of work, but that's I would say our practitioners would see that multiple times every day, or certainly with all new patients. That's why we focus on the talus so much, is because when you have an inversion sprain, the ATFL, it gets affected over 90% of the time, and that's the key ligament that maintains the integrity of the position of the talus. You've absolutely got to check with that. So, Craig, I think what you're doing is just providing the clinical observation and evidence for why mobilization of the talus and the ankle, including the fibula and the related structures, is so important for podiatrists, because we see a lot of those chronic cases.
Okay, so because I know we're running out of time here, so lateral ankle sprain is a ankle joint complex injury. It's not a talocrural joint injury. It involves the various muscles, tissues, ligaments, fascia, nerves, all the way, it runs all the way through that. Certainly there can be an improvement in stride speed, step speed, stride length. All these things have been demonstrated in some of the research papers going back. If you actually can improve that through mobilization work or manipulation work. The thing about the lateral ankle sprain, it is very much a neurophysiological
as well.
target that you've got to work at. And I think although you might talk about resetting the talus, maybe it's resetting the subtalar joint. I can't use the language resetting because once you start to move, you've got multiplanal movements going on in the ankle joint complex, which is including the talus and including the navicular, and then knocking it down further onwards. So for me, lateral ankle injury is actually almost a whole foot and a low leg injury. I need to work with all those tissues, and which is why the talus can be important, but actually maybe that ankle sprain restricted navicular movement. And that's the reason why the talus isn't going. So I'm coming back to the language and that we're using again. And I think, whatever I might do joint-wise, it is going to be a very small amount. Having said that, I agree with you that you can stimulate neurophysiological feedback. Very simple little tip is once you've had somebody with a lateral ankle injury and you want to improve some of that movement, that feedback, some firm work into soft tissue work into the sinus tarsi seems to have a significant stimulating response.
Mm-hmm.
That's certainly part of it. But actually, overall of that will be the huge amount of rehabilitation exercise and strengthening work. That's what's going to keep things in place. That's where I would be coming from on that one, really. I love it. I love working with stuffed ankles, really. I don't like having a stuffed ankle, but I love working with stuffed ankles. Is that helpful? Was that answering the question, Craig?
It does, thanks. Yeah, no, I think that's one thing where I found it particularly useful clinically. But I think we've been going for 55 minutes. Time flies. We haven't got close to what we wanted to get to. So I think we might have...
As long as people want to be more, that's the main thing.
But for those that I noticed there's quite a few people joining up late. So if you come back in 20 or so minutes, the full video will be on Facebook. Later on today, Australia time, we'll have it up on YouTube. So please head over to YouTube and give us a subscribe, and our new website's up, so you can sign up for our email list, which will fire out emails when we're about to go live. So thanks to Ian and Ted for joining us. I'm just sorry we've just scratched the surface. We haven't really got to a lot of what
thanks guys.
Want to.
Thanks for having us.
We probably could have gone on for quite a few hours, and I see Robert Isaacs has just posted, I could listen to this for hours.
He needs to get.
I think that's more of a narrative on Robert than it is on
Well, I did see he posted something earlier on today that he actually had the day off work, so he's probably got nothing to do.
Let me just say to Craig and Griff, thank you very much for creating this environment to have this type of exchange and discussion within our profession. I think it's fantastic, and really feel honoured to have been asked. I totally understand Ian being asked, but I feel very honoured. Thank you very much for the opportunity to be able to share, hopefully contribute to our colleagues.
Okay, well, thanks everyone.
Thanks.